is LBC from Global, leading Britain's conversation with Nick Ferrari at breakfast.
Morning, 3 minutes after 9 on Wednesday, January the 13th. And if there has been a highlight of any sorts through the pandemic, it has been the opportunity to see the people who are at the very helm of our scientific and our medical and our political life taking those questions. And arguably emerging with perhaps the best bedside manner of the lot when it comes to medical matters is our next guest. At home as much as he is with similes and metaphors as he is with syringes and masks, I speak of the Deputy Chief Medical Officer of England, Professor Jonathan Van-Tam, who joins me now. And just prior to welcoming the Professor to take your calls, that's what it's all about, I just need to say, people are saying, why are the borders still open, or has my auntie been moved to a care home? He's not here for political questions, OK? Consider this, if you will, a bit like a number 10 press conference where, quite rightly, the Prime Minister or the Health Secretary or the Home Secretary will field the political questions. The Professor here is when I say merely is wrong, I'm so sorry, not merely, is here to answer the medical questions and the questions regarding the virus. So political questions are part of the side because it's nothing to do with his remit. And we welcome to the show Professor Jonathan Van-Tam. Good to have you on board, Professor. I trust you are well, sir.
Yes, thank you, Nick. Nice to see you.
Good to have you on. Can I ask, has Mum had the jab?
Mum has not had the jab yet. I'm hoping that she will be invited in the next probably week or 10 days. She must be very close. She's almost at the 80 points. So
she is,
yes.
Because I think when we last heard, Mum was 78 going on 79. Have we celebrated
right.
Mother's birthday yet?
Yes, happy birthday, Mum, for a few days ago.
OK, well, quickly make sure you hit those lists and we come to the first question. Good to have you on, Professor. Thank you. Your first question comes from Norman in Dartford in Kent. Your question to JVT, as he's known in the trade. Norman, good morning.
Good morning, sir. Thanks for taking the questions. I had my first Pfizer jab, and the second one was due last week and was cancelled. There's no data, as I'm aware, from Pfizer that agreeing to delay it. Can you tell me what data you have, or am I taking part in a massive experiment?
And this is just to remind my listeners, I know, Jonathan, Professor, you'll know, this is initially, the feeling was in Pfizer you needed the follow-up within 21 days. That, as my understanding, has been moved to a period of weeks. We know with Pfizer that may be of concern, and a lot of listeners have that concern. Professor.
Thanks very much. So I do understand the concerns that people are raising about this, but let's be very clear, first of all, that the second dose is not cancelled, it is deferred. And we will definitely come back to the second dose, and it is very important to come back to the second dose. But kind of moving from the outside in, the first thing is that we are in a constrained supply situation. Now, there's been a great headline that the UK, and it's a true headline, the UK has secured access to 367 million doses of vaccine over the course of the end of last year and this year. But it won't all come at once. You can't make it all at once. It's not all Pfizer. It's not all AstraZeneca Oxford. And some of it is vaccine that we're committed to if it passes its phase 3 clinical trials, which we don't know yet. So in other words, some of it may fail. So that kind of big picture that we've got access to loads and loads is actually formed of, yes, it's true, but it comes in stages and it's multiple products. So right now we are in a constrained situation. And the bottom line is that we've all got older loved ones. And if we want to protect as many as we can, as quickly as possible, with a meaningful amount of protection, then the right strategy for us is to give the initial first dose and come back for the second when we've given more people the initial first dose. It's really boiling down to, if you've got two grandparents and you've got two vaccines, what do you do? Do you give two doses to one and leave the other one with nothing?
But on that idea, lastly, on this, Professor, so you decide to give Grandad the injection and Grandma because you want to afford them. How safe is it? Because initially, within 21 days, yes, Grandad should have. Are you comfortable that it can last a period? How many weeks, Professor?
Right, so I'm absolutely comfortable with that because that has been an argument that has been science tested by our independent experts, by the Joint Committee on Vaccination and Immunisation, the JCVI. And what they've done with the Pfizer data, which they've had access to, and you can get it yourself from the FDA website if you want it, is they've looked at the protective effectiveness after the first dose. And if you take away the infections that occur 1 or 2 days after you've had the first dose, which the vaccine couldn't prevent anyway, because antibodies take probably 2 to 3 weeks to build up. Yes, if you take those infections out and you look at the ones that occur after 2 or 3 weeks, then actually you get to a protective effectiveness against infection of something close to 90%. And that's really quite a lot of protection on board after the first dose.
And how long is that good for? So how long is the first dose good for,
right,
Professor?
Now, and that's a very good point, because your listener quite rightly has raised that. Yeah. And he is right to raise it. And if you take an extremely purist answer and say, where do the data end? The data end at 42 days. But if you take a science, an expert science viewpoint, it's just not plausible that the protective effectiveness is going to just kind of disappear after that point. And we're very confident that there will be plenty of protection on board right up until the second dose is given. But we will keep an eye on that.
And that window is what, 6 months? Can I hold you to that?
No. It'll be, in reality, in working practice, it'll be 10 to 12 weeks.
10 to 12. And lastly on this issue, Professor, can you mix and match? That is to say, can you have the Pfizer that's topped up by the AstraZeneca or the Moderna?
At the moment, you can't. And the reason for saying that is that you have to do the science experiments and understand if that is possible.
I see.
And if you get a good antibody response with a different kind of vaccine the second time round.
I see.
I think that's really important science work that needs to be done anyway. But I don't think it's going to be done in time to affect what we are doing in the next 3 months, which is getting those people vaccinated with the first dose, as many as possible, as quickly as possible.
Norman, you're in a good place. Thank you for the answer, Professor. Look after yourself, Norman. Be well. Debbie in Whitstable, you're through to Professor Jonathan Van-Tam. Go ahead, Debbie. Good morning.
Good morning. My question is, with the onset of these different variants of the virus, especially the South African strain, what happens if the vaccines we're using now aren't compatible with those variants? What's the plan?
Professor.
Right, thank you. That is a really good question again. And the first thing to say is that I understand that this is a science concern. It really is a science concern that the virus can change, and that we have to be on our guard to make sure that the virus doesn't outwit the vaccines we have. And this is a normal situation, if you think about it, for winter flu vaccines, where we have to change the strain every year to match what we think is going to be circulating in the winter. Now, that science work with the variant in the UK, with the South African variant, is all underway at Porton Down. And we will be getting results from that in due course, but it is slow and difficult work to do. And so it's not a matter of a quick test and you get an answer a day later. So whilst that is a science concern, I really don't want any listeners to be too worried at this point. And there are 2 reasons for that. One is that we know that the vaccines make what we call a polyclonal response. They make lots of different antibodies to different types, basically. And therefore, the idea that a mutation of the virus would in one go outwit the whole of the vaccine is pretty low. And so if we were to see an effect, it would be a small degradation rather than going off a cliff. But I don't think we feel that's very likely, but it's something that scientifically we've got to get to the bottom of.
Professor, do you think, much as we now have the flu jab each year, in time we will have the COVID jab that we'll have to have every year?
You're absolutely right, Nick. I can't say it'll be every year yet. But I can say that I don't think we will ever eradicate coronavirus. What I think we will do over time, and that's what we're planning to do over time, is to make it largely vaccine preventable in the same way that flu is, and to be able to live with it safely. And I think this virus is going to change anyway over time, and we may need to reformulate these vaccines periodically.
So how long is this one good for? The current Modernas and AstraZenecas, how am I good for it when I get them? And your mum, is she good for a year? Is she good for 2 years?
How long is a piece of string?
Really?
We don't know that yet. I would say it's going to be many months that the vaccine is going to work for, but I'm not basing that on data. I'm basing it on a hunch. But what we will do is we will be doing the studies to look at antibody levels in people who've been vaccinated and keep an eye on those over time, so we can kind of spot when they're drifting down. And also Public Health England will be doing the surveillance of people who are admitted to hospital, who get infected with coronavirus, who are vaccinated, because no vaccine is 100% effective. And if we start to see that the vaccine effectiveness is wearing off over time, that will be another signal that we possibly need to revaccinate people. But I do think what you're saying, the way you're broadly framing it, that this will be a repeat vaccination programme of some sort, is quite reasonable, and I agree with you.
Debbie, thank you. Nikkei in Potter's Bar, you're on the radio. Good morning.
Good morning, and thanks for taking my call, Prof. and Nick. So I work for the NHS as a pharmacist, and I'm also of Black African origin. I'd like to know how many Black and ethnic minorities were recruited into these trials, and what was the outcome data for those particular minorities. And I'm asking this question for a particular reason. I've had lots of questions from the neighborhood, from people that actually are afraid to take this because of this. So I'd like to...
Sorry, I want to just clarify, Nick. Sorry, you know people who are frightened to take the vaccine? Who are being... because, really? Gosh.
Yeah.
Okay.
Yeah.
Okay, well, this is a key question. Stay on the line, Nikkei. Thank you. Professor?
Right, so I'll chop... Thanks for the question. It is really important, and I do understand that there is this worry and concern out there, and it worries me that there is this concern out there. So let me chop the answer up into bits. First of all, there is no biological reason why these vaccines would behave differently according to ethnicity or race. That's the first thing to say. The second thing to say is that for the Pfizer vaccine, and unfortunately I don't have those data right at my fingertips today, it's annoying me, but it's in the region of 30 to 40% of the participants in the Pfizer trial, which was done in the US, were either of Black or Hispanic origin. Don't quote me exactly on those percentages because I can't remember them exactly, but it's not a small proportion at all. And in the for the AstraZeneca data set, which was obtained from trials in multiple countries, one very large trial took place in South Africa, and 80% of the participants were Black, and another large trial, a very large trial, took place in Brazil. So from that perspective, am I confident that the vaccine has been assessed in different racial groups or ethnic groups? Absolutely so. Am I confident that there won't be a difference in how the vaccine works in those groups? Yes, I am so. Right. Have I seen the data cut down, split up by ethnicity? No, I haven't. But the manufacturers would have had to declare such a thing to the regulators if it existed, and they haven't. So my assumption is, and I think it's absolutely the right one, is that this vaccine is not only safe and effective for everyone, it's really important, particularly for Black and minority ethnic groups.
Really important question, Nikkei. Thank you for that. Just lastly, on the 3 different vaccines, Professor, we know your mum is standing by waiting for the call. Would it bother you whether she had AstraZeneca, Pfizer or Moderna?
No.
They're all as good as each other. Just get the jab in your arm.
Okay. Not at all. I think you've got to frame this in terms of not only what should I have, but when should I have it? And if I have it, is it going to take me from 0% protection against coronavirus to a pretty high level of protection against coronavirus? And am I at high risk of dying from coronavirus? And for somebody of my mum's age, the answer to all of those is yes.
Yeah. Let's get to the next question. Chloe in Eastbourne, you're through to the Professor. Go ahead, Chloe. Good morning.
Good morning. I'm currently shielding. I have an autoimmune disease and I have no immunity because of the medication I take. I also work in a school. If I was to have the first dose of the vaccination, would I be safe enough to come out of shielding and go into work before I have the second vaccination?
Professor.
Thanks for the question. So this is a difficult one, and this is what I'll say to you. First of all, I hope you get the vaccine soon, and you will have a lot of reassurance from knowing that you've had the vaccine, and I hope you will have a lot of protection on board. But it is the same for everybody with a damaged or weakened immune system, that they can't fight infections, but it can also mean that they don't respond quite as well to vaccines, which is a kind of fake infection, if you like, designed to get you the antibodies without having the disease. So every individual is going to be different, and I couldn't say personally what your response is going to be to the vaccine. Where we are in terms of the advice, and this is the bit you want, is that until we know more, until millions and millions, tens of millions of people have been vaccinated in the UK, and we understand what that has done to disease levels generally in the UK, then I want you to follow the advice, and I want all shielded people to continue to follow the advice, please. If you like, we've got to create an environment of kind of surround sound, where not only are you vaccinated, but the people you bump into, so that those exchanges, they're vaccinated too, and that increases the level of protection for everyone. And then if we get the whole level of disease right down in the population, then the chances of you meeting it at all are much, much lower. And it's that subtle blend of all those things that have got to come together before the experts, we can advise the government that we're in a much safer place. And right now we're not. We're in a very dangerous place. As you can see, it's very precarious for the NHS in many parts. Infection levels are dreadfully, dreadfully high across the whole country. Vaccines are good news.
Yes,
they really are good news. But this is not over in a day. This is going to take months.
Indeed, it is going to take months. Are you a little disappointed that yesterday 145,000? The government hope was about 250,000. And some GP surgeries are going so fast, others can't keep up. Are you disappointed by that, Professor?
I understand the concerns. I was out vaccinating as well yesterday in a clinic late on.
I'd love to turn up and see you. You or Chris Whitty holding the syringe. I would feel very confident to see either of you two, Professor.
And, people are going as fast as they can. I know that the NHS has really big ambitions and really big plans to expand, to get GPs in their own surgeries on board with vaccination. We've got the mass vaccination centres. I am pretty confident that we're going to get up to figures quite a bit higher than that, and quite soon.
So just lastly, you're not disappointed about the slow start?
I understand that there was a slow start. And I understand that we had to be cautious and make sure everything was running smoothly and that we could scale up in a safe way. It's all about safety too, remember. But yes, I'm very confident.
Chloe, be well. Perhaps check with the clinician before you actually go back to school, and thank you for your call. Shirley in Watford, you're through to Professor Jonathan Van-Tam. Go ahead. Morning, Shirley.
Good morning. My lovely mum is 87 years old and has spoken to her GP 3 times
to try and get the vaccine. She was told she couldn't have it. She was allergic to penicillin, aspirin and wasp stings. We pursued it when we realised the official cautionary advice had been revised and she's now got an appointment. I wonder, will other vaccines be developed for people with allergies?
Professor.
So what you can't really do is develop a vaccine for people with allergies. What you can do is develop vaccines, and what every manufacturer does is put the minimum number of additional ingredients into a vaccine that they can get away with to make a safe and effective product. They don't put things in that they don't need, and the regulators don't allow it. But there are things that need to go in, and there will always be a very, very small proportion of people who are allergic to one of the things that's in the vaccine. And so, yes, you always try and get it as low as possible in terms of the number of ingredients, but by the same token, you don't actually make a vaccine that is deliberately designed for people with a range of allergies, because those allergies may not be relevant anyway in relation to what's in the vaccine. But what I would say to you is I'm really glad that the MHRA and the immunology experts who advised them have now revised the guidance, and the kind of allergy contraindications to the Pfizer vaccine in particular are much reduced from where we started back in early December. And I'm glad your mum's getting an appointment quite soon.
Shirley, good luck with that. Thank you. Paul in Ascot, you're through to the Professor. Go ahead, Paul.
Good morning, gentlemen.
Good morning,
I
sir.
was fortunate at age 81 to have the first dose of the Pfizer vaccine on the 8th of December. However, on Christmas Day, I developed COVID symptoms, and on the 28th of December, received a positive test. I'm now recovered.
Good.
I have an appointment on the 8th of February for the second dose of the Pfizer vaccine. I have two questions. Would I have actually only had mild COVID because I would have developed some immunity from the first vaccine? I'm assuming that I've developed some antibodies and T cells as a result of having COVID. Will they enhance or compromise the efficacy of the second vaccine?
Thank
Professor.
you for the questions. Very good ones. Well, as I said earlier on in the interview, no vaccine is ever 100% effective. But I would say, based on, without knowing you and your clinical details and your symptoms, that the vaccine is almost certain to have made you have a much more milder course of COVID-19 than you would otherwise have had. If you look at the AstraZeneca data, for example, the reduction in hospitalizations due to COVID is really, really dramatic, even based on the small numbers. And so from that perspective, this is going to be as big a win for all of us and for society as preventing infections. And people get very fixated on the numbers, on the percentage effectiveness. Remember, that's a percentage effectiveness against disease with symptoms and a positive coronavirus test. I would be much more concerned about not getting severe COVID and being admitted to hospital or dying. And I think that's a really important point. On your
the
second
antibodies,
point, though,
yes, Professor, can I bring you back to that, Professor?
Yes, on the second point, we specifically asked our regulator, and therefore through the regulator, the Commission on Human Medicines, the question about whether there were any issues with vaccinating people who had already had COVID. And the advice they have issued is no, please carry on.
Okay. All right. Good luck, Paul. Thank you. You sound very sound in wind and limb. I wish you good luck on the 8th of February when you get your second shot. Colin in Redruth in Cornwall. You're on the radio. Good morning, Colin. Your question of the Professor.
Good morning, Nick. Good morning, Professor.
Morning, sir.
Back 12 months ago when the virus first came to light and the social distancing rules were set at 2 metres and then subsequently 1 metre plus some PPE, since the virus has mutated and is now more transmissible, should the social distancing rules be reviewed and maybe extended to 3 metres and 2 metres plus?
Professor.
Thanks for the question. I've considered this one in my own mind, and if you think about the virus and the variant, the mutation that we've now seen in the UK and others around the world, the question you're asking is whether the new variant is really going to be capable of moving a greater distance, and that doesn't kind of fit with my biological understanding, because the distance relates to the force of the cough or the sneeze or the respiratory droplet that flies out of you. So unless we were saying that the variant made you cough in a different way or cough more violently, I can't see how you can kind of gain that extra distance, like in the kind of long jump, as it were. But what I can say is that we do understand that probably the viral load is higher with the variant, and that explains the infectiousness. So if you imagine the it's a bit too simplistic, and the aerobiologists will not like me for this, but you can imagine the kind of cloud of viruses around an infected person. Yeah. Yes, it's not that they're kind of way out here. Yeah. It's the fact that within the cloud they're much more concentrated, and the chances of you, if you breach those safety distances, the chances of you picking it up are higher, which is why its growth rate and its transmissibility is greater. Does that kind of bring it to life?
A light has gone in my head, as often happens when I listen to you. So where are you on wearing a mask all the time, the minute you leave your house? So not just when you go into a shop or whatever it might be, just walking down the road. Would you advise that, Professor?
The science on masks has changed as the pandemic has evolved. My view remains that the really high-risk environments for transmission are indoor spaces, and the government advice is to wear masks, face coverings in indoor spaces, and I agree with that, and frankly, I do that.
All right. We've got time for one more. Helena in Edgware. Helena, your question to Professor. I think you'll be the last one. Helena, good morning.
Okay. Good morning. Good morning, Nick. Good morning, Professor.
Hello.
I'm the owner of an independent nursery, and I would like to know, as a small business owner, why are nurseries set to...
Okay, it's a bad one, so and I'm struggling. Let's see if we're Professor. Helena is an owner of a private nursery. She has health concerns. Why is it nurseries are still open? Children can come in there, whereas in primary school, unless they're key workers, they cannot. Professor.
The infections that we know about in small children are very mild indeed. We understand that older children are much more likely to be transmitters of the virus, and we understand that if we this is a decision, this is getting towards a political question, Nick. It's a balance of if you take away nursery provision, lots of other things happen too, in terms of the workforce and in terms of the healthcare workforce. So it's a very difficult balancing act for government. But on the science point about the youngest children, do they get COVID in a way that's severe? Very, very, very rarely. Do we believe they have the same force of transmission as passing it on to adults as do older teenage children? Absolutely not.
Let's finish with a health question from me, Professor. It's known that you're a big football fan. I understand Boston United, your team, play Chesterfield on Saturday, and of course we're all pulling for a great result. Let's hope it doesn't go to penalties. But let me ask you this. When Boston United knock in their fourth goal in the second half with just a few minutes to go, should the players hug and kiss each other in the way they are? Professor, we see on our television, rugby players, football players, they score a goal, they save a penalty, everybody, is it not time to advise these blokes and women who play it, sorry, no kissing? Professor.
Nick, I completely agree with you. Look, we are in a very dangerous place now. We've talked a lot about vaccines. In the end, they are a good news story. But, this is like saying I'm building a big perimeter fence around my property so that, the baddies can't get in. But you can't celebrate that when you've put 3 posts in and 2 sections of fencing, or maybe a bit more in the case of the NHS so far. But, because people just go round the fence. You've got to build the whole fence, and we cannot relax until we have a very substantially vaccinated population. And until then, we are in a dangerous place. And you look at the NHS, we are in a dangerous place now. Every close human contact that is avoidable should be avoided, because 1 in 3 of us will get the infection and have no symptoms at all. So I'm afraid, yes, on the football point, on the sporting point, I do agree with you.
Yes, and indeed, lastly, 2 other teams, one might be from London and one might be from the Midlands at the end of the game, and it's very good-natured, the lads all and the women. They shake hands, and a great game, well done. But sadly, that's probably got to end as well, because London have just brought it up to Birmingham or Liverpool or Leicester or Boston and vice versa.
Yeah, I mean, right now, let's be very clear, disease levels are very high across the whole of the country. It would matter a very great deal more if we had a really patchy distribution of very high areas and very low, and sporting exchanges like that would make more of a difference. But it's just the basic point about we must, for now, and Chris Whitty's said this, and he means it, and I mean it too, that we right now have just got to stay at home, keep off the streets, keep out of the shops, keep away from each other, unfortunate and unlikable though that is, and let the NHS do its job dealing with these thousands of people who are sick, and let the NHS do its job rolling out the most ambitious vaccine programme that we've ever undertaken.
Privileged speaking with you. Good luck to you and all the men and women working with you, and thank you for your time today on the radio. Professor Jonathan Van-Tam, Deputy Chief Medical Officer for England, appearing here on LBC. We're at 9:30.